That's lovely. Thank you, Sandra. And welcome everybody to the meeting of Angus Health and Social Care Partnership Integrated Joint Board on today, the 22nd. Welcome everybody, and I hope you are all well. And could I just state my thanks to all our staff who are incredibly busy at the moment. Our services are pretty maxed out, I think, but we are working hard and coping, and all of that, of course, has an impact on most of the people in this meeting today. So I do appreciate your time here. Before I start, could I just pitch in a wee reminder to anyone who has an outstanding register of interest to get that into Karen Maley as soon as possible, please. That would be fantastic. Thank you. And on that note, Karen, do we have any apologies for today, please?
Thank you, Chair. We have apologies from David Mackenzie, who is the new appointment to be confirmed today on agenda item 4. Apologies from Barbara Tucker. And we have Dr. Emma Fletcher in the meeting. She's to leave at 3 o'clock, and Sarah Dickey is arriving later. That's all the apologies, Chair.
Thank you very much. And just in advance of appointments, I have met our new carers rep a couple of times, and along with Sally and Gail, thanks to the support and engagement of the Angus Carers Centre, and it'll be great to welcome him to the IGB, and we have been in touch this week. He'll be a great addition to the team. Okay, so next item, any declarations of interest over and above those that have already been declared? Lois, you're on mute.
There we go. I've got to declare a connection to item number 14, but I will remain in the meeting.
Any conversation? Yeah.
Yeah. Thanks.
That's lovely. Thanks very much. And on that, can we move on to item 3A, please, which is the minutes of the last meeting on page 5. Is everyone happy to agree the content of those minutes as an accurate reflection? Yes. Lois, is your hand up for a new point? Okay. Right, okay, agree those minutes. Andrew?
On page 11 of the combined papers, the second paragraph down, in response to the question raised, the last sentence, I think what I was meaning to say, maybe it didn't come out, but because I can't comment on third sector partners, but the service user representative confirmed that the data was readily available on the Public Health Scotland website. Is what it should be.
Okay. Karen, do you have that correction? That's, I think.
Sorry, I'm on mute. Yes, I've noted it. Thank you.
That's great. So with that minor change, can we approve those minutes? Great, thank you. And before I go into the action log on page 16, which is item 3B, we're going to just expect that everyone's read all the papers today. So we're not going to go over the papers in depth in advance of any Q&A. But if anyone has any questions, we will, of course, want to have time for those. So action log, Gail, are you covering this for us today?
Yes, will do, Chair. Firstly, the first point, item 6, it's noted on the action plan, there is a summary report on the agenda today, so I'll discuss that when we discuss item 9 on the agenda today. The next point we have is noted in red, for those of you can see in colour, but it's noted under the 26th of October point, item 13, the Angus and Dundee Stroke Rehabilitation Pathway Review was anticipated we would be in a position to bring an update to this meeting. Unfortunately, this has been delayed due to a number of outstanding pathway issues, and it's anticipated we won't be able to bring that forward until June, Chair. The next point was again in item 6, noted on the 24th of August 22, with regard to the directions policy and procedure. We had hoped to have that finalised by today's meeting, but unfortunately we were unable to conclude that. We are nearly there, so that will be brought back to our April meeting. Finally, the last couple of points which have been outstanding regarding the mental health and wellbeing strategy. I've noted in the minute in the action log there, but the Chief Officer, the Chief Finance Officer and the finance teams from across Tayside are working with our mental health operational leads to develop high-level strategic financial plans for mental health services. There has indeed been progress, and Chair, I know that you and the Vice Chair and a number of others are aware of that. Again, a paper will be brought back in June.
Absolutely, thank you. Of course, that affects more than us, so it's helpful to remember that. Any questions on the action log for Gail? Are we happy to take on board Gail's narrative around that and when scheduled? Yes? Thank you. Okay, not hearing anything there. Okay, so can we move then on to item 3C, which is the minutes of the Audit Committee from the 7th of December. I don't know if Andrew, as Chair, wants to comment on those.
Not comment on the minutes particularly, but thanks, Chair. Our next audit meeting for 2023 is actually 27th of April. So, but we did have a development session in January because there's quite a few new and recently joined people. So that was quite a useful way to start the year off, and the Chief Officer attended that throughout the whole session. So nothing to report as to the previous minutes. Thank you, Chair.
Thanks very much. And are you enjoying chairing the Audit Committee?
Yes, it's great fun. Thanks, Chair.
You're welcome. Good man. Good answer. Right. Can we agree that the Audit Committee minutes are a true reflection of that meeting, please, for those who were in attendance? Yep. Excellent. Thanks. Saw a thumb there. Okay, so item 4 is appointments. And is it Gail or Lewis that are taking us through that?
Chair, I don't know if Lewis is there, but I think they're self-explanatory. I don't really feel they need any explanation.
Okay, I would like to make note of thanks to Sarah Dickey for her role as the registered nurse representative on the IGB. Just to thank her very much for her contributions and to wish her well moving on. And oh, you're there, Sarah. Good show.
Chair, I think we need to deal with the 4th recommendation.
Yes, I was just going to go on to that after I reiterated my point about David Mackenzie joining us as the carers rep. I'm very much looking forward to that. And yeah, do you want to talk to that, Lewis, or are you? Do we need an appointment today, or is that something that people can volunteer for?
I think we could possibly deal with that today. I wonder whether Sandbout's nominations for that.
Okay, thanks, Lewis. I'll pick that leading question up. We do actually have a volunteer, and I was hoping Elaine Henry was going to be on the call today, but I'm not sure Elaine's in the meeting. It doesn't look like she was in the meeting earlier, because Elaine has volunteered to join the Audit Committee. Although she's not on today, I think I can say on that on behalf, she has said that to me, and she has been along to the Audit Committee development session that Andrew mentioned earlier on. So I think we can take from that Elaine has volunteered. If we felt we were comfortable confirming that today, I think that would be really helpful.
That would be excellent. So I think we'd all be in agreement of that. Welcome Elaine onto the audit committee. So if you can go back to the recommendations.
Chair, sorry, it's Karen. Sorry to interrupt. Can we just check that there's no other nominations to come forward, just in case there's any other expressions of interest from any other member, excluding Sandy and Gail? I don't see any.
Anyone. No.
I don't see any hands.
Okay. So
That's thanks, Chair.
excellent. Okay, so if we can confirm that with Elaine and do the necessary paperwork on that, that would be great. So noting that Sarah is moving on, that Donald McPherson is appointed proxy for this IGB, that we're approving the appointment of David Mackenzie as a carer representative, and that Elaine Henry will take up the vacancy arising in the audit committee. If everyone is happy with that, we can then move on to item 5, which is the finance report. So again, we can assume that everyone has read that. Does anyone have any questions for Sandy on this, or is there anything that Sandy would like to add in to complement the narrative in the paper?
Replicate what's in the paper. There are things in there that are more important. There's obviously a recommendation about contingencies. There's a very small error in the reserves table with £2,000 that Karen could maybe note. It's not material, and it is just a kind of a typing error. But Chair, hopefully if people have read it, I'm happy to take any questions.
Okay. Does anyone have any questions for Sandy? I'm not seeing any. Oh yes, Peter Drury
Peter.
is number 1, followed by Alison Clement. Thanks.
Thank you, Chair. On page 38, there's a significant underspend on residential care and an overspend on care in the community, non-residential care. Is that good news? And I mean, does it reflect the switch?
It may well reflect the switch. I think one of the other papers, Peter, is that we need to reset the baseline budgets for older people's services. Well, you'll be able to read that in the strategic planning paper. I think it's actually in the first recommendation there. And that is slightly reflective of the point you've just made. There are some variations in some of our, there are some variances in some of our things within older people services in particular. But what we also see is that, what I also think is happening is, because of things that have changed in our operating environment, we have not quite caught up with the way some of our budgets are configured. So I think it's hard to be, know for definite if these are good or bad things, but I think they will be resolved and addressed as we reset our budgets in that exercise that we refer to in the strategic planning paper. Is that okay?
Okay, thank you.
Okay, thank you, Alison.
It's just to highlight, based on the minutes from the last meeting, we'd asked for an update on plans for a financial recovery plan for the out of hours service for this meeting, which is still underway. It's just to highlight that that is a very difficult thing to ask for a financial recovery plan, and my understanding is that a wider bit of work is being done on a sort of more of an options appraisal approach for out of hours. I think it's worth highlighting how big that service is. That's a Tayside-wide service, and 70% of primary care, urgent care, happens within that period by that service. It does a fantastically big job that we perhaps doesn't have as high a profile as we might like, and it's just to highlight that that is no mean feat to try and do that within its current budget, and there is a bit wider work that's needing to be done around that.
Thank you, Alison. And I mean, from your point of view, is the mechanism and support in place to do that?
The situation was that there was a lot of work going on within the service, and my understanding is that it's recognised that they were needing a bit more support, so that support is being provided to get a wider, a bigger focus on how we support that service moving forward, to do something around the whole model of care and how we provide equitable care across Tayside, make best use of our workforce, and think around training the workforce for the future for urgent care, not only in hours but out of hours, valuing our minor injury units and how we could support them further. General practice in and out of hours, the practices that are struggling in terms of sustainability, but there has to be a real focus on perhaps we need to invest in teaching, training, building our workforce for the future, and that might require resource at a time that we're trying to make savings. So it's that balance of options and risks that needs to take place, and that work is, I understand, taking place, and I think it's worthwhile perhaps IGB want to consider that. There's a paragraph that Sandy's included, the work that's required, much bigger than a paragraph would cover. It may be worth the IGB being cited on that.
That's helpful, thank you. And I guess offline we can pick up any timescales around that in discussion with Gail, perhaps. Yeah. Okay. I can see we've got. Is that? Are you happy with that, Peter? Or have you got a follow-up question? Okay, Andrew Jack next, and then.
Thank you, Chair. I don't know how I got guest in there, but anyway. While not wanting to minimise the COVID remobilisation and the reconfiguration of services due to COVID's been mentioned 72 times in the pink. There's a kind of, I get a feeling that there's a tendency or a trend to kind of blame COVID financial issues. Maybe I'm wrong, but I get that kind of feeling. My question is, how long is it until the impact of COVID in an adverse way will stop featuring in our commentary in financial papers, but specifically recruitment as well? I just get a feeling that we should move on a bit now. I don't know if that's a valid comment, but it's just a feeling I have. I don't know if we could comment on that. Just an observation.
Well, I was going to come in there, but I see Alison Clement has come back in on. Is that something you want to answer, Alison?
Yeah, well, I guess it's a point for when we consider our updated performance report. Our ability to progress with actions has been inhibited by COVID, and it means that we're behind where we needed to be. And I think there is a increased likelihood of ill health because of people not being able to get out and about, deconditioning, that we need, but absolutely we need to stop talking about COVID and say this is our baseline with our next strategic commissioning plan, and this is where we're going, and keep referring and saying, well, we've got a good excuse. We know why it's happened. It's not about making excuses. It's now looking at where we are, what we're going to do moving forward. For me, I suppose that comes out really in our performance report, where we've had an extension for an extra year, and really we need, from my perspective, get into the next strategic plan.
Thank you. Thanks very much. And we are still dealing with various issues on the back of COVID, Andrew, health related. So, for example, there was a 32% increase in the number of cancer referrals for diagnostics in the last reporting quarter on the Health Board's Public Health Committee. So that is a significant increase there. I guess we still don't know the full picture yet in terms of public health data. Sandy, did you want to come in for that? I know there are other people coming in on new questions, I think.
Chair, I can maybe come in at the end. I've got comments on a series of things that have been made, so maybe let things go through and then I'll just feed back at the end.
Brilliant, thank you. In that case, Nikki is next.
Thank you, Chair. Just obviously at the moment there's lots of discussions around the negotiations for National Care Home contract for 23 and 24. I was at a Scottish Care Surgery on Tuesday where there were many providers from across Scotland, and the appetite for a National Care Home contract doesn't sound favourable. I mean, obviously that's not, nothing's been recommended or anything, but I just wondered in terms you know, if the vote is against a national care home contract, how that would affect things from a budget point of view. So that's kind of learning for me as well. But I think obviously it's, you know, from what, you know, providers were saying, it's not looking likely that it might be something that they would vote in favour of. And that's maybe happened in previous years. I don't know. So I just kind of wanted to raise that. Thank you.
Okay, so we can pick that up at the end if you're okay with that. It might be that Gail and Sandy have contributions to make on that one, Nikki. Gail's next anyway, and then Sandy.
Sorry, Chair, my point was really for Andrew Jack. I did wonder if Emma Fletcher was on the call. I think Karen said Emma was there, and I wondered if Emma would have been able to answer Andrew's question. And if Emma's not there, maybe we could get more of a position paper for Andrew, just an update, Chair, for Andrew.
She is there, yeah.
Yeah, I think unfortunately we're going to experience the legacy of COVID in a number of different ways for a good number of years to come, both impact on workforce, on economics, and the economic position is incredibly challenging for a number of different factors, and also health legacy. We're not going to understand the full extent of it for some time yet, but unfortunately it will be indirectly impacting through a number of mechanisms the health of our population, and indeed impact onto our workforce through a number of different mechanisms also. So yeah.
Thanks, Emma. Appreciate that. And Sandy.
Okay, thanks. I'll just come back about a few comments that have been made. I'll actually start with that COVID one, given what Emma's just said. I agree, and in my own notes, I was just kind of thinking about what to say. Is there are legacy things, Andrew. Emma's mentioned a couple of them. Workforce, that features in lots of our reports, and I'm not particularly talking about the clinical, the care impact or the clinical impact here. Things like workforce, you are going to have a legacy impact of COVID, and also the overall economics. And even if we just reflect on things that we've spoken about in the last 10 or 15 minutes, things like the changes in out-of-hours services, which we mentioned a few minutes ago, things like the way that the National Care Home contract might pan out, are all indirectly, or maybe a bit more directly, linked to things that have fallen out of COVID. So I think we are set a reference point in terms of there was a before and there will be an after, and different things will reach that at different points in time. The financial impact, I think, on an ongoing basis is relatively small. We'll still refer to it in this year, and that's, you're absolutely seeing that in the reports, Andrew. That will go when we go into the new financial year, and the references from a direct finance perspective are quite limited in the strategic financial plan paper. They're covered at 5.9. So the references to it, certainly in my reports, will diminish, but there is going to be a kind of an ongoing legacy, and we will, I think, for many years think back to the period before COVID and the period after COVID. Let me just come back on a few other points. National Care Home contract, Nikki, you asked about that. What would happen if the waning appetite of providers to engage in a National Care Home contract was replaced in terms of not having a National Care Home contract? That would be, I think, detrimental to somewhere like Angus in terms of our ability to coordinate our efforts in terms of the management and potentially the proliferation of local contracts. And we would have to have a plan B around that. That would be potentially quite a lot of work. There could be a financial impact of that. I don't know how that would pan out, but there is a risk associated with things like that. Alison earlier on responded to the questions about out-of-hours services, made a point about out-of-hours services, and you noted the relatively small comment that we have in there, but it is a much bigger issue, and you absolutely would recognise that. We've used the term recovery plan. That was the original terminology we had in circulation, but it could be a much deeper piece of work. I know if Jo Galloway was here, she'd probably be saying we are hoping to bring something back to the IGB at maybe the next meeting or the meeting after. So they are working on it. But in terms of what Alison said, it's maybe become a bigger piece of work and would therefore take a bit longer. And finally, I'm just going to correct something I said to Peter right at the beginning in response to his first question. He was asking me about, I didn't pick this up straight away, learning disabilities, the shift between residential and non-residential care. That is also covered in the strategic financial planning paper at section 3.3 of that paper, Peter, where we do recognise there is an imbalance there. It needs to be covered in baselines. I answered the question as though it was all the people services. Sorry about that.
Thank you. And Alison Clement is coming in next, please.
So very quickly, it's related to the cancer increased referrals by GPs. When we are referring, if we indicate our thoughts as to whether somebody might be at risk of having cancer, and the feeling is that GPs are more often saying that someone is suspected of having cancer when they're referring, because they're worried that if they don't do that, they'll be on their really long waiting lists. So the impact of the waiting list situation in NHS Tayside absolutely does have an impact on general practice, because we're managing people perhaps with painful conditions that are not getting their treatments. We are managing the anxiety associated with the waiting and the illness, the likelihood of falls. So that does have an impact. So the work that's ongoing, and that's the Cancer Care Board, for example, is just up and running. That's not been running for a couple of years. So we've got the quality improvement support, the general practice representation around these tables, looking at the pathways and trying to make sure that we get the right people seen quickly, but also acknowledging the impact of the waiting list for more routine conditions and the work that's going on. But it does have an impact on the community when we've got these long waiting lists in secondary care.
Thank you, Alison. I hope that is helping fill in some of the background around Andrew's question there. And I see Richard Humble is coming on there.
Yeah, no, I agree with Alison. It's difficult. Sometimes we have just had to put people more urgent because they've been waiting for a long time because they've been long waiting list. Paradoxically, the interesting is that people that did come forward a lot of people didn't come forward during COVID because they assumed they weren't to bother the NHS. And so there's a backlog of people with possible cancer symptoms. The ones that did actually, and because we can direct access for a lot of scans, for CT scans, they actually got seen more quickly because there wasn't a waiting list for scans. But now that outpatients are running again and the routine stuff's going, we're finding that the waiting list for like urgent CT scans things are longer, whereas used to be sometimes a week you could get them done in because of none of the routine clinics were requesting them, but now we're back to the usual. So it's obviously the ones that did come forward during COVID actually and we could directly refer for a scan if we suspected it. Often sometimes got diagnosed earlier than they would have done pre-COVID, but as you say, you have to sometimes mark things urgent because the routine waiting list is horrendous. And if you are suspect there's something, urgent waiting lists for some of the clinics like gastro and things for a scope are still about, I think, 12 to 16 weeks we were quoted. So it's still quite long. So you have to, you sometimes have to upgrade them. And also they get told if they phone the clinics, they get told that your GP can make it urgent if you think it's urgent. So it's obviously there's probably an element of that in as well, because people's conditions change as they're waiting. But yeah, no, it works both ways during COVID. So.
Yeah, absolutely. And just to confirm, these things are being tracked through various committees at NHS Tayside, and I think that it may have been the care governance one that I was thinking about, but that data is getting collected regionally and nationally. So yeah, it's still an emerging picture. Right, thank you. I'm not seeing any more hands up, so could we go back to the recommendations then on page 30 of the combined papers? Are we prepared to accept the overall projected position of Angus IGB for 22-23 and support the recommendation to amend the reserve policy to increase the contingency general reserve to 3% of turnover, which is an increase in provision of 0.95 million. And also thank Sandy for all his work on this. We all happy to accept the recommendations on that paper? Yep. Thank you very much. And thanks, Sandy. And moving on to the next paper, which is, if you'll just let me catch up with it, is item 6. It's the budget settlements with Angus Council and NHS Tayside. Again, this is Sandy's paper. And if anyone has any questions, I'm sure Sandy will be delighted to respond. No, I'm not seeing any questions. Sandy, is there any? Oh, Alison Clement here.
Oh, sorry, I didn't mean to do that. Sorry.
All right, okay. You're getting Sandy all excited there. Okay, I think it's fair that, you know, there could well, this is a work in progress budget settlement, so Does no one else have any comments or questions at all for Sandy on that? Happy to accept the position and the recommendations as noted on page 43, that we should accept the proposed budget offer from Angus Council and should accept the proposed budget offer from NHS Tayside as well. Okay, thank you very much. And moving on to item 7, which is the Angus IGB Strategic Financial Plan. And again, there's a long list of recommendations there. I hope everyone has had the chance to read it, and Sandy will field any questions on that, I'm sure. Oh, Sandy, coming in.
Yeah, if that's okay, Chair. Yeah, I think most members will realise this is the most significant of the 3 papers. This is a big forward look paper for us. You'll see from section 12.1 there are strategic shortfalls going to appear in our financial plan that will require us to rework or further develop some of the work in our emerging strategic commissioning plan. That is a circle we're going to have to try and close out, and we'll try and do that for the next IGB. There are big things in here, Chair, and you'll all know them. Inflation is a big issue for us. There are multiple risks throughout the plan, and we've got a small financial reflection of that. Have made a step change in the way we're expecting services to deal with local service pressures, and we've described that in the paper. But happy to take any questions, of course.
Okay, Andrew Jack. Alison,
Hi, Chair. Just thank you. It's just a clarification I would like, please. On page 51, 4.2, item 2, last paragraph, last sentence and last paragraph. What does neutral mean in the context of hospital unscheduled care? What does neutral mean? Thanks.
Okay, thanks, Andrew. So a lot of the things that we'll describe in this paper have either maybe a beneficial effect on our financial plan or ability to afford things, and some things have a detrimental effect. So, for example, inflation has a detrimental effect. Funding coming in from the Scottish Government has a positive effect. What we're saying here is there have been changes and there is movement in the hospital activity over a long period of time and since COVID. But there has been some debate with NHS Tayside about some of these issues, and there is a risk. But at the moment, we're kind of assuming there is neither a good thing or a bad thing. We've not built in something for this to make it a pressure that we think we'll have to absorb. We're kind of saying there is something there that might happen. We don't know quite what, but we're kind of saying it has neither a positive nor a detrimental impact on the plan. So it's kind of neutral from a financial perspective. Okay.
Thank you.
Okay, does that help you, Andrew? Is that okay?
Yeah, thanks. It was just a clarification. Thanks.
Okay. Alison.
So my point is in relation to the prescribing and the request for the local prescribing management group to come back with a recovery plan, which I'm going to take over the chair of that group, and I am the owner of the prescribing risk, and Scott Jameson is in the process of becoming the risk manager. We are looking at how we address the risk. It is clear to us, though, that we need to have the programme support in place to enable us to make these changes. At the moment, we are doing our best with clinical colleagues, but if we are serious about making these significant savings, then we need to do something that requires quite a lot of work, and it does need the operational management buy-in and the programme management and improvement support required. But certainly we are meeting very soon, and there are several meetings in the diary to progress that. We have done the easy things, and our position in NHS Tayside around polypharmacy, the amount of elderly people on a lot of drugs is quite favourable compared to average. We have made loads of progress Tayside-wide on some of the more dangerous opiate and gabapentinoid prescribing. So we have done things that are important, and it's going back to Andrew's comment saying around the COVID-19 landscape and the pressures of pharmacy staffing have limited resource directed to developing prescribing change interventions. I would just like to highlight that all the regional interventions that were asked of the pharmacy team are on track, and we have worked very hard and engaged in the prescribing incentive schemes, but the capacity within general practice, probably not related to COVID now, the capacity in general practice is very stretched to be able to respond. So absolutely committed. We have got, fully acknowledging we've not made the progress that we'd have liked to, and we're committed to making that progress, but we do need that support in place with regard to programme management to make sure that we are able to make the impact that we're being asked to, and also would like to make the links to the prevention and proactive work, which should hopefully provide alternatives. We've got some areas of higher antidepressant prescribing, initiatives like that. That's a complex intervention. It's not just a savings target, so we do need that analysis of what works, and we are trying through that bit of work to put that in place, but it does need the support. We are committed, but we need the support.
So Alison, can this IGB do anything to help you receive that support?
I think it's just maybe an adjustment or acknowledging with that recommendation is subject to having the appropriate improvement support prioritised, and if there was a commitment to that, I think that would mean that we could take that forward. But there's a slight complication in that the prescribing support unit and the pharmacy resource and the clinical governance around pharmacy is overseen by NHS Tayside, and that's because pharmacy is a complex area and it was appropriate to retain the governance, whereas the locality pharmacy strategic planning would be with Angus Health and Social Care Partnership. So there's some clarification required as to who's responsible for what, and looking at roles and responsibilities and aligning that, and that conversation is being taken forward at the moment.
Okay, after we've brought in Richard and then Sandy, maybe we need to amend that recommendation slightly to accommodate that. Richard.
Yeah, no, I agree with Alison. I mean, I think we're sort of past the COVID thing. It's just the capacity in general practice is still where everyone's still pretty stretched, and it's various reasons. I mean, recruitment, and also we've not managed to recruit a lot of the additional staff, and obviously pharmacists, physios, etc., to help take workload away from us, like was the original plan, and the GP workforce is going down as well. I mean, the prescribing budget's always been a little bit of a difficult one, because the fact that it'd be interesting to see Scott's data when it comes out. It always feels like it's always been a bit artificial, and it never seems to change much when there's, over the last sort of 10 years, more and more stuff has been shipped out of secondary care, and we're prescribing it straight away now. So you never see a huge increase in the budget for all those things. And certainly what I've seen as a trend, certainly in my practice in P&K, is that we're getting lots of wards now in terms of saving their own money. It's like they're giving the one catheter bag to go home, or two, or a couple of dressings. That's it. Get the rest from your GP. And obviously that all counts into the budget. And the other big problem, also partly Brexit and supply issues, is that whenever you try to go to some of the cheaper options and we do the prescribing changes, the pharmacies can't then get them, and there's a supply problem, and we end up using more expensive ones or in branded ones sometimes, just because of supply issues, and it's almost like swimming against the tide the whole time. So it'd be it's a useful piece of work. It'll be interesting to see what Scott's data and Alison Group can work on. But I think we have always tried to do lots of prescribing incentives and prescribing changes in conjunction with the practice pharmacists, but you sometimes feel like you're swimming against the tide the whole time, and whenever you get 2 steps forward, you end up going a step back again. So it'll be interesting to see what we can do. But yeah, if we get a massive influx of GPs again, we might be able to kind of do more, or we find where all the pharmacists are hiding, and obviously encourage some help from the central belt next time there's a new wave of new posts. So but yeah, it is an ongoing problem.
Steady on, Richard. I think we'd seen some improvements on the pharmacy budget in Angus pre-COVID, and it has slipped back, as you say, 1 step forward, 2 back. Sandy, do you want to come in on the back of that?
Yeah, thanks, Chair. Yeah, a few points I'll just kind of make some comments on. Just kind of working the way backwards. Richard, you mentioned your supply issues. They absolutely translate also into a cost issue. So for every difficulty we have accessing a supply of a particular type of drug, there are many drugs that we just about are able to access, but they'll be coming through on premium prices. That's not a local issue. It's absolutely a national issue, probably a global issue, but it's something that's certainly feeding through into our thinking and our projections going forward. Richard, you also mentioned drugs kind of coming across from secondary care. We do work hard through the regional prescribing groups to do what we can to deal with that properly. It is a struggle, but if there's any issues that we ever felt we needed to kind of escalate to a regional discussion, we would try and do that. Related to that, though, is the issue of new drug treatments becoming available. That's something that we've got down as a financial risk when a new drug is coming through, and how we manage that introduction, if it's replacing something else or it's just a new drug that's delivering health benefits. How do we manage its introduction and also afford to work with it? Just again, go back to Alison's comments. I totally support, by the way, the requirement to have a support mechanism and support infrastructure around the work that we need to do. A lot of the things that we're looking at here are not, in terms of the pressures that we're having to manage, they're not unique to Angus. They are happening kind of across Scotland. But we still do need often to create either a regional or local response to that. It will almost certainly be a mix of those two. We have only this morning at the regional meeting spoken about regional responses, but we do need to have that support mechanism that allows the likes of Alison and others to develop a local support. So I'd be quite happy to kind of endorse the addition of the fact that we need to have a support mechanism around the prescribing work.
Okay, thanks very much. I think we'll come to that in a second. Emma wants to come in now.
Yeah, thanks. I think it would be remiss of me at this point not to point out the huge value of primary prevention. I mean, we're talking about ever increasing healthcare demands across the whole system, and I know that we're particularly talking about community prescribing, but secondary care medicine spends also is escalating phenomenally. So it's just also to really bring back a focus as well across IGB members in terms of the value of primary prevention. A lot of the meds that we're prescribing are for complex health conditions that are a feature of the socio-economic commercial context in which we live, which is very sad. So thank you.
I endorse Emma's comments there. So Richard?
Yeah, sorry, just a quick comment back again. The other thing I forgot to mention is obviously the supply issues obviously take up a lot of the pharmacy technician and practice pharmacist time as well, sorting those out. So the things that they'd be able to do other things. So it has a double whammy, as it were, because they're not able to do other things in terms of prescribing incentives. I actually support Emma's thing about primary prevention as well, because just getting time to do that and getting that done and cutting out some of the drugs that are needed would be useful. But it's as I say, it's just managing the work with the workforce we've got. It's just an ongoing struggle, isn't it? So, and
I know our social prescribers are helping in part, part of that journey. It's not primary prevention per se, but they may well have an impact on prescribing, as I've heard anecdotally. If I can then take us back to the recommendations, and if we can agree wording for recommendation 5, which is the prescribing management one, asking them to provide plans to address financial gaps. Would it be appropriate to put and support requirements regarding prescribing as part of the next iteration? Or Alison, do you have better wording for that? Or a commitment to support requirements or resources, something in there.
Yeah. Sandy's got, I'm thinking improvement support is what we're needing.
Okay.
Yeah, you could just add on at the end of that sentence, I would probably say something like noting the need for the executive management team to ensure the improvement work is properly supported. That'd be okay.
Okay, I think we've got agreement on that. If Karen's able to have captured that, yeah. Excellent. So with that amendment, are we all happy to agree the recommendations as stated in the papers? You'll be pleased I am not going to read all through them. Thank you very much, Sandy, for your work there. And okay, if we can then go on to item number 8, which is the strategic planning update. And I think, Gail, I've got you against that.
Yep. Gillian Galloway's off, as you're aware, Chair, so I'll lead into this, but Sally Wilson is in attendance as well if there's any questions. I don't propose to read through the paper again because it's explanatory, but by way of the current position, our strategic planning group is currently reviewing the strategic commissioning plan, as many of you on the call are aware, and we're developing our plan for 2023-2026. Our market facilitation document and our housing contribution statement are also being developed, Chair. It is proposed that the revised strategic commissioning plan 2023 and to 2026 and the accompanying delivery plan will be presented to the IGB for approval at our next meeting on the 26th of April. You can see all the way through the report the activity that is underway. Also the prevention and proactive care work, the joint proposal work is mentioned at section 3.5 on page 62 of the bundle. Our members are asked to note the progress, as we've said, and Sandy has already mentioned in the IGB strategic financial plan a number of the above projects that are running behind schedule at the moment or are at risk of not being progressed as well, Chair.
Okay, thank you, Gail. Anyone have any questions or comments for the paper? Peter Davidson.
Thanks, Chair. Yeah, thanks, Gail. Just on the 3.5, prevention and proactive care, this is a really welcome point. I'm aware that there's a number of charities, not just in this local locality, but others, that are being proactively approached by funders because of their previous work around doing upstream preventative methods. So I think the third sector is really well placed at this minute in time to be part of this type of work. So I suppose I'm just looking for, and I know Hayley's on the call as well, but I suppose just looking for a little bit of an update as to where we were with this in Angus. I know it says it's been progressed, but yeah, a little bit more narrative around that would be really interesting. Being placed in the third sector too, it can contribute to some of the sharing of information.
Yes, good point. Whether we can bring along a paper at a future meeting. Is Sally still on the call before I bring Hayley into the conversation too? Is Sally there?
Yes, I'm here, Gail.
Oh,
thank you.
Okay.
Thank you for your comment there, Peter. And yes, Hayley is a member of our Prevention and Proactive Care Programme Group, and we are intending to hold a stakeholder meeting in the next month or so to really look at what we're doing and map out our assets and what we need to do in the future. So we'd be delighted to welcome you along to that. But it's very reassuring to know that there is that you're being approached by people, because that upstream work is just so important, as you know. And a recent publication from Public Health Scotland has just really reinforced and endorsed that this is so important for us to do.
Excellent.
Thanks.
And Emma has her hand up, and it'll be on the same thing, I have no doubt, and that'll maybe give Hayley time to get her ducks in a row.
Yeah, no, to echo previous contributions, I really welcome the focus on prevention and proactive care. We have a number of programmes that are precarious in communities across Tayside at the moment due to lack of recurring funding. The Public Health Committee last week we discussed Rest Buddies, which and Hayley may wish to talk about this following, but we have no confirmed recurring funding for Breast Buddies in the Angus area, and we would welcome Health and Social Care Partnership support around this. Similarly, there are other areas of community-based activity, primary prevention programmes that are at risk, and as I say, just very much welcome the focus around that preventative work. Thank you.
Hayley, I'm going to bring Hayley in first and then Alison.
Thanks, Chair. Yeah, I think absolutely just echoing what Emma had said there's and Peter, to be honest, there's a large amount of third sector activity across Angus at the moment looking at that preventative and early intervention care, and I think that having this group with Sally, and I know that Blair Finlay, I don't think he's on the call, but he certainly leads on this work for Angus, which most of you all know. And I think it's a real opportunity to bring all of this together in one place and really look at, well, what needs are we meeting at this time, and what is our third sector contributing, and where do those resources actually sit? Because I think that's all part of the transforming services agenda and how we move forward. And I think a lot when we talk about the transforming service, we refer to it like we have to pick that back up, because we're on talking about COVID, because that stopped during COVID, and actually, in my opinion, none of that work stopped. That work excelled during COVID, and all we were actually presenting is transforming services in action. And I think with this prevention and early intervention across the third sector, that's exactly what we're doing now, and there needs to be more of that. I think in regards to funding opportunities, and certainly thinking about more specifically Breast Buddies and other smaller preventative projects that really just aren't getting the opportunity to be taken to that next level, I think there's something that we all have to take a bit of responsibility in doing, and looking at, well, does it make sense to be funding something that we've done for 4, 5, 10 years and actually it's not making that much an impact on people's health, or do we go that upstream option and really look at, well, how do we target an issue before it becomes an issue, basically? And that's what we're doing a lot in the sector at the moment, and I think really exciting times are ahead, and I think we need to look at how we can continue that work together as a health and social care partnership and an IGB. So I look forward to welcoming some of this work moving forward.
Thank you, Hayley. Alison.
So this work's come as part of the consideration within the strategic planning group around how we prepare for the future with an ageing demographic who are increasingly in an age group that historically has been frail, and how we prevent or delay the onset of frailty in order to make sure that we're financially sustainable, because things couldn't continue. There's a real risk for me around how we ensure that we are putting the evidence base of benefit in, but also around the things that are going to give us the cost savings most quickly. So it's not just about the evidence base, it's about being cost effective. And I would, and it's difficult because you have lots of initiatives that are great, and I absolutely am a great fan of breastfeeding, absolutely support breastfeeding, but then we are the Health and Social Care Partnership, so what is within our gift to have funding for, and children, and perhaps are not our remit compared to elderly, which are clearly our remit, although I fully acknowledge we've got a remit around primary care. So the main or some examples of main focus of this group at the moment are around GIRFE, so getting it right for everyone, making sure that people are not focused on making sure that we don't have stigma around mental health. And so that is our focus work in the Scottish Government, and we have decided to focus on falls, making sure that everybody with falls, regardless of their circumstances, is getting access, and hoping that that learning can then be translated into the wider work of the partnership. The clinical evidence base for interventions is very important to us, and we're taking a lot of the work through our Angus Clinical Partnership Group to make sure, firstly, we've got the buy-in from the GPs that this is a way of working that they're going to be engaging with, but also that we've got the evidence base and we don't end up funding things that are less likely to have the benefits that we're looking for. And that is around the prescribing budget and making that link very clear. And the point around short-term funding being an issue is very well made, and we need to get away of this programme of work informing what is going to be funded in the longer term, and again where we're going to stop spending money. And that's why having this oversight group, the steering group, is proving really beneficial, because it's bringing the clinical input, the financial input, the project management, everything there in one programme of work. And you know, we need to make sure we're linking with the inequalities work as well. So it's going well. I would welcome a board development session, perhaps, or linking with what Sally's saying. You could come to us, I guess, with our engagement event, but perhaps there needs to be a board development session around the prevention and proactive work stream.
I'm always up for development sessions. I'd be happy to support that. Emma first, and then Peter Davidson.
Thank you. Just very quickly, I mean, child health has to be a public health priority for all of us across the whole system. If we can't get it right for our future generations, we are just not going to be able to deliver sustainable healthcare into the future. So I appreciate that the reactive pressures around falls within the Health and Social Care Partnership and the frailty and ageing population, but in order for us to be able to avoid the challenges of those and reduce the challenges of those in future, we have to get it right now for the generations coming through. So just to ensure that balance across. Thank you.
Thanks, Emma. And Peter?
Yeah, thanks. Just I welcome Alison's suggestion about a board development session. I'd written something down similar here. You know, Hayley will agree. The third sector are really keen to be as impactful as possible, but they don't always know what the future looks like or what the future issues are. So at a public health meeting we had recently, we spoke around the role of health intelligence in informing not just NHS side, but the third sector that want to complement the work. So a board development session with health intelligence included, but for me also the NHS side endowment fund, particularly the Charitable Funds Committee, because again that fund exists to be put to good use, particularly within communities, and sometimes we lack real innovative upstream project ideas for that fund. So that would be a useful addition to said group for a development session. So thanks for that, Alison. Thanks, Hayley.
Well, I hope everyone heard that invitation from Peter there. He's going to be beating applications off with a stick very shortly. But he is making a really good pitch for it, so bear that in mind. Okay, so that was a really good discussion. I appreciate that. Can I take us back to the recommendations, which is asking us to approve the content of the report and the recommendation that the deadline for completion of the strategic commissioning plan is reset to our next scheduled IJB meeting on the 26th of April. Everyone happy with that? Yeah, thank you very much, everyone. That's great. Right, just bear with me till I get to the next page. Right, we're looking at item 9 now, which is the Angus Living Life Well Summary Update Report. And this has Gail's name attached to it. I'm taking it that everyone has read it. First of all, Gail, if you've got anything you want to add to this in advance of questions, please do.
Yeah. Firstly, can I make a point of minor amendment? Chair, I want you to note in the background 2.1, the Living Life Well Implementation Plan for Angus, Report 3722 was approved at the June 22 IJB with an update, and it says in your paper, Report 5522, that in fact should read 8722. So that's an amendment. Karen, I trust you'll note that as well in the minute for me, please. Thank you. In relation to the paper, it was previously requested at our December IJB that a summary update would be brought forward. I think 2 of the members required some information and further clarity around the monitoring and assurance of the Angus Living Life Well plan, and also regarding the equality impact assessment part. Terry Irvin is also on the call regarding this. So if there are any questions on the paper, Terry is also in attendance, Chair.
Excellent. Thank you very much, Gail. Does anyone have any questions for Gail or Terry on this? All gone quiet. Sorry, I'm just scrolling through myself.
Lois, I think, has got her hand up.
Excellent. Good show. Thank you, Lois.
Yeah, thanks. Yeah, I'd already spoken to Terry before the meeting, but it was really just a comment around it would have been helpful to have a link perhaps to the plan with the report. So especially when looking through the quality impact assessment, you could cross-check what was being done to mitigate against the plan. But other than that, I was happy with it.
Thank you. We can take that on board for future reference. Yep, seeing nods. Okay, in that case, can we note the report and agree to a further report in June 2023? Thank you very much. And moving on to, just let me get there, to item 10, which is Mental Health Services report. And could I also assure you, you'll have seen the appended letter that I received from Fiona Lees attached to this. I have responded officially to that and copied in Gail and Peter Davidson as Vice Chair on that. But I thought you'd all want to see that, which was a very positively framed letter. And I appreciate all the support that Gail and Services and Angus have given to support the independent report. Does anyone have anything they want to add to the narrative before I go to questions? No? Okay, any questions on this paper, please? Obviously, it's a significant ongoing piece of work, and we do get regular assurances on what is happening with it. And I'm particularly keen to point out the special IGB meeting that's been called for the 27th of March, so that we can just consider our detailed action plan. And that was obviously to fit in with the timing required of us by the Scottish Government to get that action plan in by the 31st of March. It is cutting it fine, but we will get there. I am confident. Yes. Alison.
Yeah, I just wanted to highlight around the clinical governance arrangements for mental health and learning disability. We have a clinical governance group for our 4 mental health and learning disability services within Angus, and there was a decision made to have a centralised group. And I just wanted to highlight concerns. I mean, I wasn't aware of this group before it was put in place, but certainly I have considerable concerns around the lack of consultation with myself as somebody who has chaired the group locally for 6 years before the announcement was made. It certainly my equivalents in the other 2 health and social care partnerships had a similar experience. We have concerns around the value of having integrated response support for clinical governance, looking at health and social care together, and we have quite a strong structure in place for supporting our teams with regard to that in Angus, with an assurance framework that covers all the 6 getting it right for everyone framework agreed areas of care. We've had an extensive report from our community mental health team, which showed a great improvement over time and is associated with an improvement plan which covers all of these areas. And I am concerned that this group has been put in without due consideration to consulting how it would link with us. These concerns have been raised and we have had meetings regarding it, and I've had an assurance that in future we'll be able to work more collegiately across the whole system around mental health and the clinical professions, recognising that specialists in mental health will have oversight of the things that we need specialist mental health to have oversight, such as giving us strong standards around quality of care issues that they have the expertise in, things like ligatures and the NICE guidance for ADHD, but also that in the partnerships might have experience of equal value in how we integrated teams across populations, integrating with general practice and make it actually work on the ground, and all the low level, so-called low level mental health, but how we can act proactively with prevention, proactive care. And for me, that bit has been lost. And I see that the clinical governance group is described as being around patient safety. For me, there needs to be far more influence on clinical leadership around clinical quality standards and pathways. I mean, what is the right thing to do for somebody with a mental health condition? It's not described in the same way it is for physical health. So I absolutely welcome that we've got this far with mental health, and the governance from a managerial perspective has been agreed. We now need to work on the clinical governance, and there is an absolute commitment across all 3 health and social care partnerships, and the operational medical director for mental health and the nurse director for mental health. We are absolutely agreed around the need to have these conversations and move forward. But I would want to highlight that I would see in the future that we need to ensure that these conversations happen at an earlier stage, and there's a greater recognition for our local clinical leadership. And Gail's aware of this. You know, this isn't something I'm saying, but I do feel it needs said because it's important to me, and I think we've got.
Thank you, and I hope Peter Davison doesn't mind me updating you on this informally, but there was a meeting of the IGB chairs and vice chairs on Monday around the mental health meeting that we'll be having with the Minister in due course on the back of this, the independent oversight group. And we were all very eager that there was a development time put aside for all the partners so that we can look at the whole journey of care and support involving stakeholders, including obviously private, the third sector and service users, in a way that took the whole development seriously. We were really keen to do that, and that is a conversation in progress. I gave Gail the heads up on it. I know she's supportive of that approach, and I know that Jackie Pepper in Perth and Kinross is as well, and I've alerted colleagues in Dundee to that too. So we are very much looking at a whole system approach to this, and watch this space. Is that a fair summary, Dave, Peter?
It is, Julie. Yeah, I think that's helpful for committee. I think it's worth at this point. It's not a question, but this is a really difficult area of work, but a really important area, and I just want to thank everyone that's been involved in it thus far. And I think if Fiona and Elise can go off mentioning Gail's leadership as being commendable, I think we should take this opportunity to do so at the meeting. So Gail, thanks very much for your contribution thus far.
Absolutely, thank you. And yes, you're right. It is complex, but there is a passion and commitment for taking it forward in the right way. Okay, does anyone else have any comment or question to add? I'm not seeing any more hands. If we can go back to the recommendations on page 75, there are 4 recommendations there. Without reading them all out, is everyone happy to accept them as stated in that paper? Yes. Excellent. Thank you very much, everyone. And then on to item 11, which is the joint inspection of adult support and protection in Angus. And again, it's Gail's name on that paper. I'm sure you've all had the chance to read the actual report, which came out in advance of this meeting, as well as being integrated in the papers. Does anyone have any questions? No, I'm not seeing any hands. Any comments?
Chair, if I could come in there again to acknowledge the work of Fiona Rennie, particularly Fiona Davidson, Fiona, is at the meeting today, but it's to acknowledge her leadership around this and getting us to this stage, Chair. I think that's important to note.
I would, yeah, absolutely support that. And you know, inspections like this create a huge amount of extra activity for lots of different people, and that's over and above their routine workload. So Fiona, thanks to you, and could you pass our thanks back to all those involved in that report? Thank you very much for that.
The next stage, Chair, is obviously to finalise the improvement plan, which will be based on the findings of the inspection, and that's to be submitted to the Care Inspectorate by the 15th of March. Bearing in mind this is a multi-agency inspection and a multi-agency improvement plan, so it's important that we capture all of that. And appreciate there are relevant committees that needs to go to, but we need to ensure that we've got a full multi-agency report.
Thank you very much. And the recommendation is that we acknowledge the outcome of the inspection, which was, I thought, a hugely positive one. And I'm always so proud of our staff in Angus for accepting any learning from reports like this and really integrating them into practice. So thank you all very much. Fiona, you've got your hand up there.
Could I very quickly just highlight that since the report has been submitted for the IG, I've received some further information in relation to how Angus has performed and the results of their inspection nationally. So far there's been 19 inspections taking place. There's 41 performance indicators that are graded as part of the inspection, and at the moment Angus have come out at the top of the table. I had a meeting with the inspectors last week, and they highlighted that normally every inspection report will have 6 areas for improvement and 6 areas of strength, and Angus had 5 areas of improvement and 8 areas of strength, and that was in recognition of our highly effective processes. So I just thought that would be helpful for the board to hear about where we're sitting from a national perspective.
Well, that's excellent, Fiona. Thank you. And that is just a ringing endorsement of what everyone has said around the report and the way we deal with those. So thank you very much. That's something to be pretty proud of, I would say. So on behalf of the board, thank you all. And I think we are happy to accept the recommendation of acknowledging that report. Thank you. And moving on now to item 12, which is our equalities mainstreaming update. And I think we've got Eunice. We've got Eunice, yeah. Yes, for that. If we have any questions relating to this report, thank you for bringing this to us, Eunice.
Thank you, Chair.
Do you have anything you want to add before anyone has any questions? Are you quite happy for it to stand?
Quite happy for it to stand, thank you.
Okay. Okay. I know it was, we just saw this in August last year because we were running a bit late on that, but we've obviously caught up to speed now. So thank you for that. George.
Thank you, Chair. When I read this, in particular the EIA, I firstly wondered, did it actually need an EIA in that it's actually an update on another report? But looking at the EIA, for instance, on page 356, it asks a series of questions on its impact. And the response, there is a paragraph there. It talks about travel and help with travel for those that might find it difficult if they had to travel. It then talks about question 2, material deprivation, and it says as above. 3, impact area deprivation, as above. I don't see how the help with travel that answers all these questions. But as I said earlier, I'm unsure whether it was actually needed. And I think going on, page 358, it does a similar thing, where it asks about protected characteristics. Positive impacts, we say, yes, there's a positive impact. And then what it does is cuts and pastes all of those to gender, disability, ethnicity, sexual orientation. And I just sometimes wonder whether the EIAs, maybe in some cases, they're a bit of an add-on, and maybe the time isn't spent that should be spent on them. Thank you.
Thank you very much for your comments and your observations, Councillor Meakin, and I accept your points around that we have just referenced above, and perhaps we should have been more explicit in our responses, and we'll take that on for future EIAs. So thank you for that.
Thank you.
Okay, thank you very much for that. I'm not seeing any. Oh, Gail, sorry, just caught you there at the bottom of my screen.
It's more
and Lois.
It's more to assure Councillor Meakin, absolutely not. They are definitely not. I think it's important that we look at each EIA, but actually perhaps we need to be more transparent through the actions that we take as a result of the EIAs that go alongside. So that's something I would want to do in the future.
Lois.
Yeah, just to say that I've kind of raised similar to what George has raised before, and yeah, and had the same assurances at that time. So yeah, I still feel that there is improvements to be made, and sometimes it does feel like it's an add-on, and I know that everybody's time is tight, but yeah, sometimes think maybe even if it was to be on the front of the report template, so that it's at the forefront of the report writer's mind, that we should be focusing in on the equalities impact. Yeah, that's all I want to add.
Okay, thanks. And then Eunice, and then Morgan.
Thank you. Sorry, I should have also said that we're doing quite a lot of work around this area, and there's going to be further training and development on this. So we had to focus on the key priorities first, which was getting our equalities work underway, getting things on our website, etc. We've done all that, but we're not finished with our equalities work, and part of it is developing our EIAs. And I think that's a good point Councillor Speed made about perhaps that should be the first thing that we do and have that first. So we can certainly take that back to the working group and consider that as we go forward. So thank you for that.
I quite like the idea of having the EIA at the front of a paper, actually. So that's maybe worth exploring. Morgan, have you taken your hand down? Yeah, has Eunice covered it?
Morgan was going to come in with what I'd said, so thank you.
That's fine, that's fine. Okay, so sorry, just let me get back to the beginning of the paper, which is to approve the content of the report, I guess, with the acknowledgement that there's work to be done on that in light of the comments that have been raised. Okay, happy with that? Marvellous. And then if we can move on to item 13, which is our mid-year performance update. So there's obviously quite a lot of detail in here. So I'm happy to field any questions. I've fielded them off to the right person in the call. If anyone's got anything they would like to know more about. And Andrew, Jack, you're the first up.
Yeah, it's a good report, that, actually. I like these kind of red, amber, green things. I'd like to share a good news story and just wonder how that could actually fit into the dashboard. I don't see where it would be, but just from a personal point of view, I had to go to an outpatient orthopedics appointment and was referred back to primary care because of continuing issues I've got with rehabilitation after revision surgery. So it was recommended that I should get some physiotherapy. So a letter went back to the GP. When I got my letter from the outpatients, I contact GP, and I within 24 hours I had a physiotherapy phone call, an emailed list of personalised exercises to do, and a referral on to supervised physiotherapy in the secondary care sector, I guess. Because of my postcode, it was referred back to King's Cross. And that's where the good news stopped. I fell into this 13-week minimum vortex waiting time. So credit where credit's due. I think the primary care response was excellent, and I'll stick something in care opinion about that. The primary care. I think does the physiotherapy come from the primary care setting as well? And where is that captured is that integrated primary care responses? I think the way it was all joined up, I was very impressed, but I was kind of disappointed when it went into the, and we've heard the reasons for it. Richard mentioned it, that there are delayed COVID backlogs that are probably holding people up. And I'm not urgent anyway, so it probably wasn't flagged up as urgent. So that kind of spoiled my pathway. So just like to, support you hear a lot of bad stories about GP services and primary care, and that was a good news story for me. So not so good later on, though.
Okay, thanks for that, Andrew. Richard, do you want to come in on that?
Yeah, I suspect that was probably kind of First Contact Physio, which is obviously one of the new services set up with the new contract. And basically they're really quick. I mean, obviously the setup things, so trying to kind of quick fix rather than having to wait to see a GP and contact them directly for musculoskeletal problems. The difficulty then is if you need to see a physio face to face in the normal system, it's the same in P&K, and it's about a 13-week waiting list, and that's where the delays come. I suspect sometimes that's why the hospital clinics sometimes tell you to contact the GP rather than just referring yourself to physio themselves, because they probably get quicker through the First Contact Physio system. But I think the problem is it's workforce. There's a limited number of physios, and certainly I think some of them that are doing First Contact Physio work in the other areas as well, and they're shifting people around. There's not a huge number of new physios. That's the only problem. So it's but yeah, no, it tends to work fairly well. It's one of the success stories of the new contract, certainly in terms of getting people seen quickly and taking work away from us that we just be referred to someone else anyway. So yeah.
And Sally's just prompted me that we'll have lots more good news stories to share now that we're rolling out care opinion. So it'll be really good to promote the availability of that, so that we can capture stories like that, Andrew, and hopefully smooth out those wrinkles in the process that you're talking about, which I think is really important. Okay, and I'm not seeing any more hands up on that paper. I think one of the areas that I am quite interested in keeping an eye on is the number of falls. And I've heard mention that Angus seems to be a bit of an outlier in that, but that might be a reflection of our demographics. And I know there's a lot of work going into to address that and to support people in terms of falls prevention. So thanks very much for that report. And is everyone happy to look at the three recommendations on page 367 and accept them? We're acknowledging the content, and we've got further improvement work to do where in the red areas where targets haven't been met. Sorry. And we're reviewing those local indicators for the annual report. Everyone happy for that? Okay, I'm not seeing any dissent there. Thank you very much, everyone. And on to item 14, which is the Learning and Physical Disability Priority Improvements paper. We've got two recommendations in front of us, approving the content of the report and noting progress to date, and approving that updates on this plan will be brought by the strategic plan update in future. Again, taking it as read that you've read the paper. Any questions? We've got Linda Kennedy here. Any questions, anyone? Eunice?
I was just going to say thank you. I'm also happy to take questions and lead on this paper. for the partnership. So I think it was just an opportunity really just to show the developments of where we've been and what work we've done, but also where we're going in terms of our direction of travel going forward. So thank you for that.
Okay, thank you. Let me get that. Oh, and Sandy's got his hand up there.
Yeah, less a question and more an observation. There are finance tables in this. This is the kind of thing that we need to strategic planning and linking with the commissioning plan. You can see that there's been challenges in delivering some of the previously assessed targets in those tables, and that's again symptomatic of some of the things that we've seen across the whole IJB, and not just this year, but during the years of COVID. So just a flag that this is an example of things that we're having to deal with and build into future iterations of our plan.
Okay, absolutely accept that. Okay, I'm not seeing any more. Oh yes, I am now. That's great. First of all, Alison, and then Lois. I don't know if there's a time lag on my little hands.
Yeah, it's worth considering where we are with our performance, not so much related to our targets, which were created when we were not expecting COVID to happen, but in relation to other partnerships. And I think if we looked at that, we would see where we are relative performance, and that would be quite helpful for us. But certainly our admissions and our delayed discharges are comparing favourably, and it's worth acknowledging all the work that's gone into that.
Absolutely. Thank you, Alison. Lois.
Sorry, just have we skipped what agenda item are we on?
We're on 14.
14, Lois, but Alison was commenting on the item before.
Okay, that's fine. Yeah, I just got a little bit confused there. It was more just if Eunice could give a little bit more, can just elaborate a little bit more with regards to this report and the direction of travel. It's obviously it's quite broad in terms of what's the content of the report.
Okay, so we'll just really outlined. I think these reports were coming regularly to the IGB previously. The last one was updated in August 2021. And this is about us trying to shift the balance of care to support more people in our communities and support people to greater independence for longer. That's what aligns with our strategic plan. So it's really just to highlight the objectives that we've been trying to undertake in that period of time. You'll note in the report that there has been some delay in improvement activity as a result of other pressures. We do now have a senior planning officer in post, which is really positive, and under that you will see some of the work that we have done in that period. We've already cut later on today, there's a further paper on green paper about one of the aspects. We're also going to be reviewing our accommodation, we've done stakeholder engagements, and we're looking at our learning disability database. So quite a lot of work is being progressed. We're also starting our coming home report, and implementation group has been established. Our second meeting is due for that next Friday. We are reviewing daycare services for people with physical disabilities, and also reviewing our capacity and criteria for our adult resource centres for people with learning disabilities, as they are heavily oversubscribed. We are also trying to implement annual health checks for people with learning disabilities. That's a requirement from the Scottish Government. And we're also considering the need to develop a framework for decision making and eligibility criteria for complex care packages. So that's really what I'm talking about in terms of our direction of travel. That's quite a few significant strategic pieces of work that we are going to be progressing as we go forward. I hope that's helped to clarify matters, Councillor Speed. Thank you.
Yeah, thanks. So just, for further clarification then, so all that work that you've described, there will be future reports come to IGB then in terms of an update and further.
I'm not sure in terms of an update. I think what we'd agreed was that any updates would come in terms of under the strategic plan, because this will sit under the strategic plan. So key strategic performance issues or directions that we're looking for will come to the IGB, but some of this will be put into operational practice as well as routine operational business. But key things will be brought forward, of course.
Yeah, I think that's covered in recommendation 2, Lois.
Did see that, yeah, but
And I would expect that if there was an exception that required a separate paper, then we would deal with that routinely within our governance structures. Does that seem reasonable?
okay, yeah, I did see that,
Okay.
yeah, in the recommendation, but just wondered in terms of clarity around, yeah, whether it was a big decision or whether it was, yeah, a more smaller operational. Thanks.
I think from the way I see this, it's not about the size of the importance of it. It's about bringing everything under the one roof, if you like, in terms of our strategic plan and the direction of that, rather than separating it out for reporting purposes. I don't think bringing it into the strategic planning reporting diminishes its importance.
Okay.
Is that fair? Yes.
Yeah, I think if I can add in, Councillor Bell, that's kind of our view was that it was about trying to be succinct and put key things under the arenas that fit nicely together. So it is strategic decisions. We also do other improvement plans that we haven't brought to the IGB, and we felt that we should try and merge things. And obviously, if there was some key significant decision that we're looking for out with the norms of the strategic plan, then we would bring that as we would do with any other matters as well. So please be reassured about that.
I'm really pleased to see the project support come into place, and having worked across all the resource centres in the past, such a valuable resource that we have in our community. So it's interesting to hear that they're so over subscribed. Okay, I've got Andrew next and then Alison.
Thanks, Chair. I'm not familiar with the Scotland Excel framework, so could I get a quick description of that, and how will that benefit the partnership? Is it a kind of financial benefit, or is it something else?
Okay, I think Eunice, you want to come in and do a quick summary of Scotland Excel.
Well, it's basically a sort of national framework that most local authorities and partnerships are signed up to, and it's about commissioning and about negotiating with different bodies. So it does help us financially that all the negotiations have taken place through one body, and we can try and get a consistent approach across Scotland. So it's something that Angus Council and the IGB have signed up to before, and we're keen to progress on to that, because it is about good value for money and about consistency and approach.
Good. Thank you very much.
Okay, thank you. Hope that's helped, Andrew. It's probably about as much detail as anyone wants as well. Okay, Alison.
So I would just support this being considered as more within the strategic framework, and that is because it links with equalities for me, it links with integrated teams and the focus on prevention and proactive care. There's a lot of this report, or historically when we talk about learning and physical disability, that is about housing and the sort of care home high-end cost areas, and I understand the value of them, but there's much that we should be doing for all of our population who have learning disability or physical disability. And when we've got this project support in place, part of what we're doing is around the learning disability, physical health checks, and how we work closely as integrated teams to look after people's physical health needs, their mental health needs, their support needs in terms of any disability, and how we get that working efficiently and effectively, and not just within services, but across a system of care. So I'm really quite keen that we think of this as part of our strategic commissioning plan through that route, for that reason.
Yeah, thanks, Alison. Lois, are you back in with a different question? Oh.
No, sorry,
Okay.
on you go. Sorry.
Thanks. Okay, Catherine.
Thank you, Chair. I just wanted to note that I think it's very helpful that the report specifically talks about engagement, and I notice there's an active engagement strategy laying out how some of that will take place, and obviously if there are to be particular proposals developed or decisions, then I imagine that we will also get some detail around the engagement that's taken place and the consultation that's taken place, so that we are quite clear about that at the point that the IJB is asked to make decisions. And the other element was, just also to suggest, although it's not specifically mentioned in the report, that there's some benchmarking undertaken with other areas in terms of, again, looking to make sure that we've got read across, so that people who are moving into Angus and moving out with Angus experience less disruption in their care than they might otherwise do. It's just a good opportunity to see if there's something we can align with out there.
Okay, great point. Thank you very much, Catherine. I'm sure that's been picked up. Okay, so can we then move to the recommendations, which is about approving the contents of the report and noting the progress to date, which is very positive, and approving the move to bring updates via the strategic plan in future. So as long as that our responses have addressed Lois's concerns, I feel that's a positive move, and happy to support that. Is everyone else in agreement? Marvellous. Okay, and before we move on to the next one, I've made a note of this. I do apologise to Tracy Bowman, who's our new non-exec from NHS Tayside, and it's our first meeting today as a member of the board. I'm really sorry for not mentioning this at the start, Tracy. It's great to have you on board, and Karen did remind me as well, but I'd already made a note of it and then it went out my head, so I do apologise. It's great to have you, and hopefully see you tomorrow as well at the board. So formally noted apologies there. Okay, so if we can then move on to item 15, which is our risk appetite paper, and that's another of Gail's papers. If Gail has anything she wants to add, dive in, but otherwise pop your hand up if you've got any questions on the risk appetite paper.
No, Chair, I think, as you'll recall, at our second risk appetite development event on the 26th of October, we reviewed and took an in-depth assessment of our risk appetite for the IJB. That draft risk appetite statement was shared with everybody and we received feedback, and as previously agreed, this would go to our Health and Social Care Partnership Clinical Care and Professional Governance Group, and it indeed went there on the 6th of February and was approved. Dr. Clement, I'm sure, can confirm that just now, and the agreement is that this will be reviewed and updated on an annual basis. So that's all I needed to add.
That's marvellous, thank you very much. I'm very happy with that. Would everyone else concur? Peter Davidson's got a question.
Really happy to see it. Thanks. Delighted that it's been through that process and approved. I suppose I'm keen to understand how it will now work in practice, and whether or not the team themselves, and it's okay if you don't work in practice. Obviously, we have some really big decisions to approve otherwise as a committee, as a board, and I just wonder when proposals are made, when recommendations are made to us by execs, how much reference is going to be made, if any, to the risk appetite against the risks that are identified in the quality assessments and the like. So yeah, just how you see it working in practice, meeting to meeting. Thank you.
Okay, I'll hand you over to Alison Clement for that.
Yeah, so we endorsed it. This is as an IJB risk appetite. It's not our clinical care and professional governance, but us Health and Social Care Partnership, people that work in the Health and Social Care Partnership, we are trying to prepare reports according to your risk appetite. So for me, one way that we should be doing this in practice is when reports are coming to you as the IJB, that we should be linking them with our Angus Health and Social Care Partnership strategic risks. So you know what the strategic risk is that this is referring to, and this for me is about aligning accountability and responsibility with the ability to do something about it. So for me, as I mentioned earlier, I'm the owner of the prescribing risk, and Scott Jameson, who is my colleague, is going to be the manager. We'll have that set out in our strategic risk, and there might be service risks aligning with it. So when we're coming to a report to the IGB, I'm bringing it as the owner of the risk with Scott, perhaps as the author, and that we can then know that we are aligning that key working within the partnership to how we produce reports to you, and then you can see where we're working on it with the mitigating actions, and it's a clear audit process for me. So that is this is how I see it working. I think there is a bit of work to do to ensure that when we're bringing reports that they are aligned with the people that have accountability for the strategic risk and that are managing the risks, and that we make sure that that's explicit within how we bring papers to you.
Are you happy with that, Peter?
Yeah, thank you. Because when you see open against workforce, I'm really pleased with that. I think we have to be I see open as being innovative. I think high would have been quite innovative there. So I suppose it's the challenge back to us all, but the team in particular who are involved in recruitment, for example, as to how innovative are we actually being to meet some of the challenges that we're currently facing. So no, Alison, that sounds great. Thank you very much for that explanation. I look forward to seeing it work in practice. Thank you.
That's excellent. Thank you. Does anyone have any more questions on the risk appetite paper? Gail, you want to come in there?
It actually wasn't a question. It was just in relation to Peter's comment there about the workforce. Like yourself, Peter, I would have said workforce was high under the leadership of Eunice McLennan. She is very innovative and comes up with many innovative ideas to try and recruit our staff, Peter. I'm sure if you wanted any updates, particularly on workforce, Eunice would be happy to provide that.
Okay, that's great. Thank you very much, Gail. So we're being asked to approve the draft risk appetite statement, which I think we have just done there, which is great. Thanks for your work on that, everyone who was involved in it. So if I can go back to the agenda, and we are on the date of the next meeting, which is item 16, which is the 26th of April, with a caveat that there is a special meeting on the 27th of March, and the venues for these will be communicated outwards. It may be that we're in the chamber again by then in person, so I'm just giving you the wee heads up about that in preparation, but we await confirmation of that. And item 17 is exclusion of public and press. So we're asked to consider the standing orders to agree whether or not to exclude public and press from consideration of the following item to avoid the disclosure of information which is exempt in terms of Part 1 of Schedule 7A to the Local Government Scotland Act 1973. Are we agreed to exclude public and press at this stage to allow consideration of the final paper? Yes, nods would be good. Yep, marvellous. Okay, in that case, can we halt live streaming, please, and give time for people to leave the room?